Welcome back to the 𝘫𝐸𝐴𝑐𝑢S USMLE video series, where we dive deep into the most frequently tested concepts for the USMLE exams. In today's video, we'll be covering some other high-yield topics that are essential for your exam prep. Let's go through a couple of key cases to help you understand these important concepts better. We have here another important topic which is frequently tested in Step 1 exam. Acute tubular necrosis is one of the most common causes of acute kidney injury. And we see in this slide a 54-year-old man who was hospitalized after suffering from an acute myocardial infarction. During his hospitalization, he went into cardiac arrest, but was successfully resuscitated and stabilized in the cardiac ICU. However, on the second day, his urine output dropped to 400 milliliters per day. And here's what we know from his lab findings. Creatinine increased from 1.1 to 2.4 milligrams per deciliter. Blood urea nitrogen increased from 16 to 26 milligrams per deciliter. Urine microscopy shows muddy brown casts. These muddy brown casts are a hallmark of acute tubular necrosis, and the question asks which renal structures are most likely to be affected. The answer is the proximal tubules. Let's break down what's happening. Acute tubular necrosis in this case is caused by renal ischemia following cardiac arrest. The renal medulla, specifically the proximal tubules and the thick ascending limb of the loop of Henle, are the most vulnerable to ischemic injury. These areas are highly metabolically active, making them particularly susceptible when there's reduced renal perfusion. A key diagnostic clue here is the presence of muddy brown casts, which are formed from sloughed tubular epithelial cells. These casts are considered pathognomonic for acute tubular necrosis. On histology, you would see flattening of the tubular epithelial cells, loss of the brush border, and necrosis of the cells lining the tubules. Now let's move on to a 32-year-old man who was hospitalized following a motor vehicle accident with multiple fractures and internal bleeding. He underwent surgery for a femoral fracture, but developed oliguria on the second day of hospitalization. This patient was later diagnosed with ischemic acute tubular necrosis due to hypotension from his injuries. The clinical course of acute tubular necrosis can be divided into 3 phases. First phase, called initiation phase. This occurs immediately following the initial ischemic or toxic insult, lasting about 24 to 36 hours. In this phase, urine output may begin to drop, but the damage to the renal tubules has just started. Second phase is the maintenance phase. Tubular damage is fully established at this point. The patient becomes oliguric, leading to fluid overload, electrolyte imbalances like hyperkalemia, and metabolic acidosis. This phase can last 1 to 2 weeks, during which the glomerular filtration rate remains low and the patient's creatinine and blood urea nitrogen levels rise. Finally, recovery phase. In this phase, the tubules reepithelize and begin to recover. However, this process takes time, and during the early recovery period, patients may experience polyuria, in which urine output increase due to impaired tubular resorption, leading to loss of electrolytes like sodium and potassium. The GFR returns to normal more quickly, but full recovery of tubular function may take time. If we were to biopsy this patient's kidneys 1 month later, the most likely finding would be tubular reepithelization. This is a high yield point. Most patients with acute tubular necrosis will recover their kidney function as the damaged tubules regenerate. Let's shift to a different type of acute tubular necrosis caused by rhabdomyolysis. A 21-year-old man is brought to the emergency department after rigorous military training in hot weather. He complains of muscle aches, weakness, and dark urine. His labs reveal creatine kinase of 22,000 units per liter, indicating severe muscle breakdown, hyperkalemia with a potassium level of 5.6, and elevated creatinine of 2.0 milligrams per deciliter, signaling acute kidney injury. Urine microscopy in this patient reveals granular, muddy brown casts, which is a hallmark of acute tubular necrosis caused by rhabdomyolysis. All right, let's break it down. What exactly is going on here? In rhabdomyolysis, the breakdown of skeletal muscle results in the release of myoglobin into the bloodstream. Myoglobin is highly nephrotoxic and can cause direct damage to the renal tubules. This not only leads to ischemic injury, but also induces renal vasoconstriction. The heme pigment in myoglobin cross-reacts with the urine dipstick, causing a false positive result for blood. But urine microscopy will show no red blood cells, confirming myoglobinuria. This case illustrates another common cause of acute tubular necrosis, myoglobin-induced tubular injury, often seen in trauma, overexertion, or drug use. Now let's look at a 65-year-old man who underwent coronary artery bypass grafting surgery for multivessel coronary artery disease. Post-operatively, he develops decreased urine output, and his serum creatinine rises from 1.3 to 2.5 milligrams per deciliter. Urine microscopy shows muddy brown granular casts, which is characteristic of acute tubular necrosis. The likely cause in this case is ischemic tubular necrosis due to renal hypoperfusion during surgery, particularly in an elderly patient with underlying conditions like diabetes and chronic kidney disease. Surgeries that involve cardiopulmonary bypass or aortic clamping increase the risk of renal ischemia, leading to acute tubular necrosis. In summary, acute tubular necrosis is a major cause of acute kidney injury and is often triggered by ischemia, such as from cardiac arrest or surgery, or toxic injury, such as from myoglobin in rhabdomyolysis. The proximal tubules and the thick ascending limb of the loop of Henle are the most commonly affected structures due to their high metabolic activity. The clinical course of acute tubular necrosis progresses through initiation, maintenance, and recovery phases, with most patients regaining kidney function through tubular reepithelialization. Key findings like muddy brown casts and rising creatinine are diagnostic hallmarks. It's critical to recognize these signs early to manage the underlying cause and prevent further damage. We have here another important topic, renal papillary necrosis, which is frequently tested in step 1 exam. First case we have here is a 21-year-old man who comes to the emergency department with a 1-day history of left flank pain and gross hematuria. He has noticed small blood clots in his urine, but denies dysuria or any prior urinary symptoms. His medical history is unremarkable, but his younger sister has sickle cell disease. On examination, his vital signs are stable, with a normal temperature, normal blood pressure, and a slightly elevated pulse rate. There is no costovertebral angle tenderness, and the abdominal examination is unremarkable. Given his presentation and family history, what is the most likely cause of this patient's hematuria? Okay, the simple correct answer is renal papillary necrosis, likely due to sickle cell trait. Let's break this down. Renal papillary necrosis is a condition characterized by ischemic necrosis of the renal papillae, and it can be caused by several underlying conditions. One of the most common causes is sickle cell disease, or sickle cell trait, where sickled red blood cells obstruct small renal blood vessels, leading to ischemia of the renal papillae. Next, diabetes mellitus is another major contributor. The vascular complications associated with diabetes lead to hypoperfusion, which predisposes patients to papillary necrosis. Additionally, analgesic nephropathy, often due to chronic use of nonsteroidal anti-inflammatory drugs, results in renal ischemia by reducing prostaglandin synthesis and causing vasoconstriction of the afferent arterioles. Lastly, severe pyelonephritis or urinary tract obstruction can compress the medullary vasculature, further contributing to papillary ischemia. In this patient, the sickle cell trait predisposes him to renal papillary necrosis because the low oxygen tension in the renal medulla promotes the sickling of red blood cells, causing ischemia. The symptoms of renal papillary necrosis typically include gross hematuria, often painless but may have passage of tissue fragments in the urine, colicky flank pain due to sloughed papillae obstructing the ureter. Macroscopically, the affected papillae appears gray-white or yellow necrosis in the distal renal pyramids, and histologically, you'll see coagulation necrosis with preserved tubule outlines. Let's move on to another case of renal papillary necrosis. A 22-year-old man presents to the emergency department after experiencing gross hematuria and right flank pain that spontaneously resolve. He had been hiking in the mountains in summer heat but has no dysuria, urgency, fever, or frequency. His laboratory findings reveal his hemoglobin is 10.4, which is slightly low, and his reticulocyte count is 6%, indicating an elevated level. Urinalysis shows 3+ blood with 20 to 30 red blood cells per high power field, but no casts or white blood cells. A renal ultrasound reveals increased echogenicity of the renal medulla, but no hydronephrosis. The most likely cause of his hematuria is renal papillary necrosis. And simply, here's why. The patient's gross hematuria, with normal red blood cells and no casts on urine microscopy, suggests an extraglomerular cause of hematuria. Given his history of strenuous physical activity and potential sickle cell trait, renal papillary necrosis is the most likely explanation for his symptoms. Sickle cell trait is common in people of African, Middle Eastern, or Mediterranean ancestry. And although patients with the trait typically don't have symptoms of sickle cell disease, they can experience complications under certain stressors. In this case, the combination of low oxygen tension from hiking at high altitudes, dehydration, and possible acidosis can promote sickling of red blood cells in the renal medulla, leading to ischemic injury and papillary necrosis. To summarize the high yield points, renal papillary necrosis typically presents with gross hematuria, flank pain, and occasionally the passage of tissue fragments in the urine. The conditions most commonly associated with renal papillary necrosis include sickle cell disease or trait, diabetes mellitus, analgesic nephropathy due to chronic non-steroidal anti-inflammatory drug use, and severe pyelonephritis or urinary tract obstruction. Renal papillary necrosis occurs due to ischemic injury to the renal papillae, with the kidneys being particularly vulnerable due to the low oxygen tension in the renal medulla. Diagnosis is often supported by urinalysis, which shows gross hematuria with normal red blood cells, and imaging studies such as renal ultrasound, revealing increased echogenicity in the renal medulla. That wraps up our discussion on renal papillary necrosis. Okay guys, let's move to next topic. Interstitial cystitis, also known as painful bladder syndrome, a chronic and often debilitating condition that affects the bladder. In this case, we have a 47-year-old woman who presents with lower abdominal pain that is relieved by urination. Over the past 2 months, her pain has worsened, and she now urinates every hour to alleviate the discomfort. She has stopped engaging in intercourse due to dyspareunia, which has become increasingly bothersome. The patient's past medical history includes irritable bowel syndrome, and she had 4 vaginal deliveries followed by a tubal ligation. On examination, her vital signs are normal, and her BMI is 27 kilograms per square meter. There's tenderness over the lower abdomen, particularly over the anterior vaginal wall, but no signs of cervical motion tenderness. Her urinalysis shows trace blood, but no bacteria, nitrites, or leukocyte esterase, and her urine culture comes back negative. Based on these findings, the most likely diagnosis is interstitial cystitis. Interstitial cystitis is a chronic bladder condition that causes pain and discomfort during bladder filling, which is typically relieved by voiding. This key feature, pain that improves with urination, is central to the diagnosis. The patient's symptoms, such as increased urinary frequency and urgency, are also classic signs of interstitial cystitis, which often develop gradually and worsen over time. Additionally, dyspareunia is a common symptom, contributing to sexual dysfunction in women with this condition. Interstitial cystitis is more common in women over the age of 40 and is frequently associated with other chronic pain syndromes like fibromyalgia or irritable bowel syndrome, which is relevant to this patient's history. The exact cause of interstitial cystitis is unknown, but it is thought to involve bladder inflammation or dysfunction of the bladder lining. Diagnosing interstitial cystitis is primarily clinical, as there is no definitive test. A thorough evaluation, including a normal urinalysis and a negative urine culture, helps rule out other causes of bladder pain, such as UTI, bladder cancer, or pelvic inflammatory disease. In this patient's case, her symptoms, along with the absence of infection or other abnormalities on imaging and laboratory tests, support the diagnosis of interstitial cystitis. Management of interstitial cystitis is focused on improving the patient's quality of life, as there is no curative treatment. Key strategies include behavioral modifications, such as bladder training and avoidance of triggers like caffeine, alcohol, or artificial sweeteners, which can exacerbate symptoms. Medications such as amitriptyline, a tricyclic antidepressant, can help alleviate both pain and urinary symptoms, while pentosan polysulfate sodium may aid in repairing the bladder lining. In cases of acute pain exacerbations, analgesics are often used for symptom control. Additionally, physical therapy may also play a role in managing pain and improving bladder function. To summarize, interstitial cystitis is a chronic bladder condition characterized by pain that worsens with bladder filling and is relieved by urination. It often presents with increased urinary frequency, urgency, and dyspareunia, and is commonly associated with other chronic pain syndromes and psychiatric conditions. The diagnosis is clinical, and treatment is focused on symptom relief and improving quality of life. That's all in this video. Please make sure to review these key points for your exams and stay tuned for more high-yield nephrology cases. Thank you for joining this episode of the Metacoccus video series. Stay tuned for more high-yield discussions on topics that frequently appear in your NBME and USMLE exams.